Welcome to Med School Content. I'm glad you're here. Today we're covering diabetes mellitus type 2 in our disease management series. And this one is a banger. T2DM affects over 500 million people worldwide. It's the most common endocrine disease you'll see on the wards, and it's guaranteed to show up on every board exam you take. But here's the thing. The way we treat it has fundamentally changed in the last decade. The old approach was chase the glucose number. The new approach is match the drug to the patient. By the end of this video, you'll have the full framework, pathophysiology, diagnosis, the modern treatment algorithm, how to manage a DKA, how to screen for complications, and a high-yield summary you can screenshot and take straight into boards. Let's go. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. To understand how we treat T2DM, you have to understand why it's a progressive disease, because that's what makes the treatment stepwise and multi-targeted. It all starts with visceral obesity. Visceral fat, the stuff packed around your organs, as opposed to subcutaneous fat just under the skin, is metabolically active in the worst way. It dumps free fatty acids into the portal circulation, releases TNF-alpha, and shuts off adiponectin. All of that drives insulin resistance in muscle, liver, and fat tissue, meaning your cells stop responding to insulin's signal to take up glucose. Initially, the pancreatic beta cells try to compensate by pumping out more and more insulin, compensatory hyperinsulinemia. But at the same time, a second problem is brewing. The pancreatic alpha cells, no longer suppressed by insulin, ramp up glucagon secretion, which drives the liver to increase hepatic glucose production. This drives fasting hyperglycemia. And then here's the brutal part. Chronic hyperglycemia itself damages beta cells further through glucotoxicity, and elevated free fatty acids add lipotoxicity on top of that. So the disease feeds itself. Insulin resistance causes hyperglycemia. Hyperglycemia destroys more beta cells. The beta cells secrete less insulin. Glucose climbs higher. It's a vicious spiral. By the time someone is diagnosed with T2DM, they've already lost about half their beta cell function. The board pearl here, the classic histologic finding in T2DM is amyloid deposits in the islets, formed when islet amyloid polypeptide, or AAPP, which is co-secreted with insulin by beta cells, misfolds and aggregates in the extracellular space, versus the lymphocytic insulitis you'd see in type 1 diabetes. Now that we understand why T2DM is progressive, let's talk about how we diagnose it. The ADA gives us 4 ways to make the diagnosis, and only one criterion is needed. But if the patient is asymptomatic, you need to confirm on a separate occasion. First, fasting plasma glucose at or above 126 milligrams per deciliter. Second, a 2-hour oral glucose tolerance test using 75 grams of glucose at or above 200 milligrams per deciliter. Third, and this is the workhorse in clinical practice, HbA1c at or above 6.5%. And fourth, a random glucose at or above 200 in someone with classic symptoms. That's the only one you don't need to repeat. Pre-diabetes sits just below each of these thresholds. Fasting glucose 100 to 125, 2-hour OGTT 140 to 199, or HbA1c 5.7 to 6.4%. Now, a quick word on HbA1c. It reflects your average glucose over the preceding 3 months because that's roughly the lifespan of a red blood cell, with the most recent month contributing about 50%. Know the conditions that throw it off. Falsely low in hemolytic anemia, hemoglobinopathies, or after a blood transfusion. Falsely high in iron deficiency anemia. On the treatment side, glycemic targets are patient-specific. The standard target is below 7% for most adults. Go tighter below 6.5% in someone who is young, newly diagnosed, not yet on insulin, and at low risk for hypoglycemia. Go looser below 8 or even 8.5% in elderly patients with multiple comorbidities, limited life expectancy, or a history of severe hypoglycemia. For screening, all adults 35 and over every 3 years, and anyone under 35 with a BMI of 25 or higher plus at least one additional risk factor. So we've made the diagnosis. Now what? Management always starts with 2 things working in parallel: lifestyle modification and metformin. for lifestyle, medical nutrition therapy to cut down refined carbs and saturated fats, at least 150 minutes per week of moderate intensity aerobic exercise, and a goal of 5 to 7% body weight loss. Even modest weight loss dramatically improves insulin sensitivity and can delay or prevent progression to T2DM in pre-diabetic patients. If the HbA1c is below about 9%, a 3 to 6 month trial of pure lifestyle is reasonable. Above 9% or with symptoms, start medications immediately. And the medication you start is Metformin, unless there's a specific reason not to. Metformin has been first line forever, and for good reason. It primarily works by suppressing hepatic gluconeogenesis, so it cuts off that excess fasting glucose production. It drops HbA1c by 1 to 2%, it's weight neutral or causes modest weight loss, and it doesn't cause hypoglycemia when used alone. It's cheap, it has cardiovascular benefit, and it's been around for decades. The question they love to ask: why can't you give metformin in renal failure? Lactic acidosis. The kidneys clear metformin, and if they fail, metformin accumulates and can shift metabolism toward lactate production, though in practice, true lactic acidosis is rare and mostly occurs in patients who have other risk factors stacked up. The practical rule: hold if EGFR is below 30, hold before IV contrast, hold during acute illness or surgery. Here's the framework that ties everything together. The 80-20-25 algorithm is built around a two-pronged approach, and this is the paradigm shift I mentioned at the start. We used to pick drugs based on how much they lowered glucose. Now we ask, what comorbidities does this patient have, and which drug addresses those comorbidities? After lifestyle and metformin are on board, if the HbA1c is still above target at 3 months, you add a second agent. And here's how you choose it. If your patient has atherosclerotic cardiovascular disease or high CV risk, you reach for a GLP-1 receptor agonist or an SGLT2 inhibitor. Both have proven mortality benefit. If your patient has heart failure, HFrF or HFpF, you reach for an SGLT2 inhibitor specifically, because the data for SGLT2 inhibitors in heart failure is extraordinary. If your patient has chronic kidney disease, especially with albuminuria, the SGLT2 inhibitor is again your first call, with finerenone as an add-on for patients who have residual albuminuria. If your patient's main issue is obesity and you need weight loss alongside glycemic control, reach for a GLP-1 RA or tirzepatide. And if none of those apply and you're just trying to get the glucose down, any agent works: sulfonylurea, TZD, DPP-4 inhibitor, or insulin. If dual therapy isn't enough after another 3 months, escalate to triple therapy or add basal insulin. The key principle: every time you see a T2DM patient, you're not just asking what their HbA1c is, you're asking what their comorbidity profile looks like and matching the drug to the patient. Let's spend a minute on the two most important modern drug classes, because they've changed the landscape of diabetes management. GLP-1 receptor agonists, semaglutide, liraglutide, dulaglutide, exenatide, work through the incretin pathway. They enhance glucose-dependent insulin secretion, meaning they only stimulate insulin when glucose is actually elevated, so you don't get hypoglycemia. They also suppress glucagon, slow gastric emptying to blunt post-meal spikes, and reduce appetite through central effects. HbA1c comes down 1 to 2%, weight drops 3 to 7 kilograms. Most importantly, the LEADER and SUSTIN6 trials showed reductions in major adverse cardiovascular events, non-fatal MI, non-fatal stroke, and CV death. GLP-1 RAs are particularly good for stroke prevention. The side effects to know: GI nausea and vomiting, especially when starting. There's a small risk of pancreatitis. And the hard contraindication: personal or family history of medullary thyroid cancer or MEN2 syndrome. SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, work by a completely different mechanism. They block the SGLT2 transporter in the proximal tubule of the kidney, causing the kidney to dump glucose in the urine. They lower HbA1c by about half to 1% and cause modest weight loss and blood pressure reduction as a bonus. The big story is cardiorenal protection. EMPA-REG showed dramatic reductions in HF hospitalization, and the CREDENCE and DAPA-CKD trials showed renal protection independent of glucose control. Side effects: Genital mycotic infections, think vulvovaginal candidiasis, are very common. UTIs, volume depletion, and the board favorite, euglycemic DKA, where a patient on an SGLT2 inhibitor develops ketoacidosis despite relatively normal glucose levels. Finally, tirzepatide is the newest player, a dual GIP and GLP-1 receptor agonist that outperforms both drug classes for HbA1c reduction and weight loss. Never combine a DPP-4 inhibitor with a GLP-1 RA. They work on the same incretin pathway, and there's no additive benefit. If you're finding this helpful, do me a quick favor and hit that like button and subscribe. It genuinely helps other students find the channel. Alright, let's keep going. These agents are still on your boards and still used in practice, just less often than the newer classes. Sulfonylureas, glipizide, glimepiride, glyburide stimulate insulin secretion by closing ATP-sensitive potassium channels on the beta cell, which triggers calcium influx and insulin release. They drop HbA1c by 1 to 2% and are cheap. But the trade-off is significant. They require residual beta cell function to work, and they cause hypoglycemia and weight gain. If you give sulfonylureas to someone who skips a meal or drinks alcohol, you get dangerous hypoglycemia. In elderly patients, glipizide is preferred over glyburide because it's shorter acting with less hypoglycemia risk. TZDs, or thiazolidinediones, and the one we use is pioglitazone, because rosiglitazone has cardiovascular signal concerns, are PPAR gamma agonists. They're insulin sensitizers. They work in adipose, muscle, and liver to improve insulin action and increase adiponectin. They don't cause hypoglycemia, and they lower HbA1c by 1 to 1.5%. But the side effect profile is limiting: weight gain, significant fluid retention and edema, fracture risk in women, and possible bladder cancer with long-term use. The hard stop: TZDs are contraindicated in NYHA class 3 or 4 heart failure because the fluid retention makes heart failure worse. If someone asks you which diabetes drug to avoid in heart failure, that's your answer, the TZD. DPP-4 inhibitors, sitagliptin, linagliptin, saxagliptin, allogliptin, work by blocking the enzyme that degrades endogenous GLP-1 and GIP, so they boost incretin levels indirectly. They're weight neutral, well tolerated orally, and have no hypoglycemia when used alone. The trade-off is modest efficacy, about half to 1% HbA1c reduction. Note, saxagliptin was associated with increased HF hospitalization in the SAVOR-TIMI 53 trial, so use caution in heart failure patients. Before we wrap up chronic management, let's tackle the 2 acute hyperglycemic emergencies because they're tested constantly and they come at you fast on the wards. DKA and HHS both represent severe insulin deficiency, but they play out differently. DKA is primarily a disease of type 1 diabetes, but it absolutely can occur in type 2, especially now with SGLT2 inhibitors on the market, where you can get euglycemic DKA with glucose below 250. Common triggers: infection, medication non-compliance, new diagnosis. The presentation is the acidosis picture: nausea, vomiting, abdominal pain, small respirations where they're breathing deep and fast to blow off CO2, and that fruity acetone breath. Labs show glucose usually over 250, an anion gap metabolic acidosis, and elevated beta-hydroxybutyrate. Management goes in a strict, predictable sequence. First, aggressive IV normal saline for fluids. Second, and here is the pearl every student needs to tattoo on their brain: check the potassium. You must check it before you start insulin, because insulin drives potassium into cells and can cause fatal hypokalemia. If it's below 3.3, hold the insulin and replace potassium first. Third, once potassium is clear, you start an IV insulin bolus of 0.1 units per kilogram followed by a continuous drip at 0.1 units per kilogram per hour. And continue the insulin infusion until the anion gap closes, not just until the glucose comes down to 250, because the glucose will normalize before the ketosis resolves. HHS is the other emergency, much more common in elderly type 2 patients. The setup is weeks of poor oral intake, progressive dehydration, and escalating hyperglycemia. There's enough residual insulin to prevent significant ketogenesis, so no small breathing, no fruity breath, no significant acidosis. But the glucose is extreme, often above 600 and sometimes over 1,000 milligrams per deciliter, and the effective osmolality is through the roof, above 320 mosm/kg. The presentation is altered mental status and severe dehydration. These patients are actually more volume depleted than DKA patients, so aggressive fluid resuscitation is the priority. The mortality is up to 15%, much higher than DKA, because these are typically older patients with significant comorbidities and a delayed diagnosis. Complications are where diabetes does its real damage. They're driven by two underlying mechanisms you need to know cold. Non-enzymatic glycation produces advanced glycation end products, or AGEs, which damage blood vessels at every level. That's behind the macrovascular disease and the microvascular disease. The second mechanism is the polyol pathway, where excess glucose gets converted to sorbitol via aldose reductase. Sorbitol accumulates in tissues that don't need insulin for glucose uptake, like nerves, the lens, and retinal cells, causing osmotic damage. Let's walk through the complications. For microvascular disease, nephropathy is the leading cause of chronic kidney disease and end-stage renal disease in the U.S. The natural history is a beautiful board story. Hyperfiltration due to efferent arteriolar sclerosis drives microalbuminuria, which progresses to overt proteinuria, then declining GFR, then ESKD. First-line treatment for diabetic nephropathy is ACI or ARB because they dilate the efferent arteriole and reduce the hyperfiltration pressure. The pathognomonic histologic finding is Kimmelstiel-Wilson nodules, nodular glomerulosclerosis. That's a guaranteed board question. Retinopathy is the leading cause of new blindness in people ages 20 to 74 in the United States. Screen at diagnosis with a dilated eye exam, then annually. Non-proliferative disease can be watched. Proliferative disease, where new fragile vessels grow, requires anti-VEGF injections or panretinal laser photocoagulation. Neuropathy affects about 50% of patients with long-standing diabetes. The classic presentation is distal symmetric polyneuropathy in a stocking glove distribution with sensory loss preceding motor loss, and the longest axons in the feet and legs affected first. Macrovascular disease, coronary artery disease, stroke, and peripheral arterial disease is the #1 cause of death in T2DM. The prevention strategy is aggressive risk factor modification, statins, blood pressure control with an ACI or ARB, smoking cessation, and the cardiorenal drugs we covered. For diabetic foot disease, it's the convergence of neuropathy and peripheral vascular disease that creates the dangerous situation. Loss of protective sensation plus ischemia leads to pressure ulcers, infection, osteomyelitis, and ultimately amputation. Annual foot exams are mandatory, and patient education on foot care is one of the highest yield interventions we can do. Managing T2DM isn't just about glucose, it's about the whole patient. The monitoring framework is simple if you organize it by frequency. Every visit, blood pressure, weight, medication review, and glucose data. HbA1c every 3 months if you haven't hit target or just changed therapy, every 6 months once stable. The ADA 2025 guidelines now increasingly recommend continuous glucose monitoring even for type 2 patients, with a time in range above 70% at glucose 70 to 180 milligrams per deciliter being roughly equivalent to an HbA1c below 7. Annually, dilated eye exam through ophthalmology, comprehensive foot exam, spot urine albumin to creatinine ratio, serum creatinine and EGFR, fasting lipids, vitamin B12 level if the patient is on Metformin, it reduces B12 absorption, and immunizations including influenza, pneumococcal, and hepatitis B. The landmark trial anchoring all of this is the United Kingdom Prospective Diabetes Study, the UKPDS. It showed that intensive glycemic control in newly diagnosed type 2 diabetics, targeting an HbA1c around 7% compared to around 8%, significantly reduced microvascular complications. More importantly, there was a legacy effect. When the trial ended and the intensively treated group relaxed their control, the benefit persisted for years. This is why we treat early and aggressively. The investments you make at diagnosis pay dividends for decades. Let's pull it all together. If you screenshot one slide, make it this one. Remember the narrative. T2DM is a progressive disease because of the insulin resistance and beta cell failure spiral, which is why treatment is stepwise and multi-targeted. You diagnose it with FPG at or above 126, HbA1c at or above 6.5%, a 2-hour OGTT at or above 200, or a random glucose at or above 200 with symptoms. You start with lifestyle and metformin for everyone. Then you build around the comorbidities: cardiovascular disease or high CV risk, GLP-1 RA or SGLT2 inhibitor, heart failure, SGLT2 inhibitor, chronic kidney disease, SGLT2 inhibitor, obesity, GLP-1 RA or tirzepatide. DKA management always starts with fluids and insulin and potassium replacement. Check K+ before insulin starts. Continue until the anion gap closes. HHS is the T2DM emergency, extreme osmolarity, minimal ketosis, aggressive fluids. Annual eye exam, foot exam, and UACR are non-negotiable for every patient. And know your drug side effects cold. Sulfonylureas cause hypoglycemia. TZDs cause edema and are contraindicated in heart failure. SGLT2 inhibitors cause genital infections and euglycemic DKA. GLP-1 RAs cause GI upset and are contraindicated in MTC and MEN2. Metformin causes lactic acidosis and renal failure. If you know that table, you know diabetes management. Thanks for watching. I really hope that was helpful. If it was, do me a huge favor and smash that like button, subscribe to the channel, and hit the notification bell so you don't miss the next one. I put a lot of work into these videos, and your support is what makes it possible to keep going. I'll see you in the next video.